For this talk, we will be presenting on an article relating to the diagnosis of liver cancer published by Liu et al. In the Clinical Biochemistry Journal. This is the official journal of the Canadian Society of Clinical Chemists. The article was published in volume 79, May 2020, and is titled Diagnostic Value of Serum Glypican 3, alone and in combination with AFP as an aid in the diagnosis of liver cancer. It explores the possibility of a novel method of diagnosis for liver cancers, which is greatly needed. Liver cancers are the fourth leading cause of cancer-related deaths worldwide, and the second in males. They consist of several types. Of these, primary liver cancer is that which begins in the liver, as opposed to secondary liver cancer, which begins elsewhere in the body and spreads to the liver. This article focuses on the categories encompassed by primary liver cancer, which include hepatocellular carcinoma, HCC, intrahepatic cholangiocarcinoma, ICC, and combined hepatocellular cholangiocarcinoma, which is also known as CHCC-CC. Of the three types, hepatocellular carcinoma is the most prominent, and it represents 85 to 90% of cases. This type of cancer is of unknown cause, but has known risk factors included hepatitis B or C, cirrhosis of the liver, and a family history of HCC. This can be seen in Figure 1, where we have the histopathology of a moderately differentiated HCC displaying a trabecular pattern. Intrahepatic cholangiocarcinoma, or ICC, accounts for around 3% of liver cancers and arises in the peripheral bile ducts within the liver parenchyma. The diagnosis for this type is quite grim, with only 15% of patients presenting with resectable disease, meaning the tumor can be removed via surgery. This remains the only complete cure for ICC. It carries similar risk factors to HCC, in addition with the deletion of the p53 gene posing a severe risk. This gene codes for a protein which regulates the cell cycle and functions as a tumor suppressor. Thus, its deletion poses an increased risk of cancer proliferation. This type can be seen in Figure 2. Combined hepatocellular cholangiocarcinoma, or CHCC-CC, is an extremely rare form of primary liver cancer and accounts for around 0.4 to 14.2%. Although this is actually considered an underestimate due to diagnostic challenges and previous lack of consensus of nomenclature. The causes are still unknown, although there is growing evidence suggesting it shares features with HCC and ICC, although it is more aggressive and has lower patient survival outcomes. Major hepatectomy, or removal of large parts of the liver, is the best therapeutic approach, despite a lack of international guidelines for its treatment. This can be seen in Figure 3, where we have an example of a biopsied CHCC. This is an example of a single tumor nodule, which contains two different histological components. The upper area contains the glandular differentiation and biliary profile of a cholangiocarcinoma, whilst the lower part of the image contains a hepatocellular carcinoma. Currently, alpha-fetoprotein, or AFP, is used as a serum marker to aid in diagnosis of high-risk HCC patients. Alpha-fetoprotein is a glycoprotein composed of 591 amino acids and is commonly used as a marker for embryonic disorders during pregnancy, although its function in humans is unknown. The sensitivity of AFP is quite low, around 25 to 65%, which causes false results in around 50% of cases, especially in the early detection of HCC. Thus, the development of a new marker for detection is of great significance. Figure 4 shows the model structure of human AFP, indicating its three domains. In this paper, the diagnostic value of glycopan 3 is explored. This is a protein encoded by the GPC3 gene and is located on the human X chromosome. It's classified as an oncofetal protein. This means that it is normally present during embryogenesis and can increase with the presence of cancer, as they originate within tumor cells. They can then enter the bloodstream either by secretion from the tumor or as a breakdown product of tumor cells. It was first reported in 1997 by Tsai et al. To be overexpressed in patients with HCC, and has since been supported by multiple studies, with positivity rates of up to 74.8%. Although its usefulness as a diagnostic tool remains controversial compared to that of AFP, with some studies reporting reduced capability when compared to AFP. This is presented in Figure 5, which is a schematic of the protein with both the N and C terminus labeled. The ultimate aim of this paper was to investigate serum GPC3 expression in a large number of patients with liver cancer to further characterize its diagnostic value.
This was a cross-sectional retrospective study performed on 264 primary liver cancer patients and 134 healthy individuals, which were admitted for routine examinations with no abnormal liver activity or history of tumors. Primary liver cancer patients were recruited on the basis of diagnosis through pathological examination or clinical medical history accompanied by medical imaging, such as ultrasound, CT scans, and MRIs. Patients were excluded due to incomplete medical records, in the presence of other malignant tumors, severe heart or kidney disease, and unavailable plasma samples after surgery or intervention therapy. The primary liver cancer population can be subdivided into 4 groups: hepatocellular carcinoma, intrahepatic cholangiocarcinoma, combined hepatocellular cholangio group, and metastatic liver cancer, where the primary site of cancer was confirmed by surgery or cytology. Diagnosis of these patients were confirmed by needle biopsy or examination of surgical extracted specimens, except for 5 cases of hepatic cellular carcinoma and 2 cases of intrahepatic cholangiocarcinoma. This study quantified serum GPC3 through an analytically validated RUO enzyme immunometric assay kit using Sandwich ELISA. The GPC3 calibrated controls and samples together with a biotinylated monoclonal antibody for GCP3 were incubated for 2 hours in streptavidin-coated 96 microwell plate. The streptavidin is a biotin-binding protein which captures the biotinylated monoclonal antibody bound to soluble GPC3. The wells were then washed and horseradish peroxidase labeled antibody for GPC3 was added. The conjugated reporter enzyme oxidizes its substrate chromatin to make its presence visible, yielding a distinctive color change which can be detected. After another hour of incubation, the wells were then washed and chromatin was added to each well for another 30 minutes of incubation. A stop solution was added and the intensity was measured using a microplate reader, the Thermo Scientific Multiscan Go, at 450 nanometers. Each sample was performed in duplicates and the average was calculated. A standard curve was constructed for GCP3 with the R-squared value of 0.999. The R-squared value is a measure of variance within a dataset to the line of regression. The analysis and results of patients' serum GPC3 was validated using GPC3 controls 1 and 2 of known concentrations which both met within the reference ranges in all batches. When measuring serum AFP, the study utilized electrochemical luminescence, which is similar to a Sandwich ELISA, although streptavidin is bound to a magnetic bead to separate the AFP-bound antibodies from the background. The electrodes induces excitations of the ruthenium and TPA, where the free radical reduces the ruthenium from its excited state to emit light for quantification by an automatic biochemical analyzer. This study found that both GPC3 and AFP were significantly higher in the primary liver cancer population than in the healthy population, although there were no significant findings when compared to patients with metastatic liver cancer. When analyzing the differences of these proteins within the liver cancer population, they found that GPC3 was the highest in hepatocellular carcinoma than intrahepatic cholangiocarcinoma. A similar pattern was observed when measuring AFP levels in the study cohort. Although the differences between intrahepatic cholangiocarcinoma and the control group were not significant, both GPC3 and AFP were significantly higher in the combined cohort of hepatocellular cholangiocarcinoma group compared to the control group. ROC curves were constructed to calculate the area under the curve and evaluate the diagnostic efficacy of AFP and GCP3. Overall, there was significant diagnostic efficacy for the differentiation of 3 groups with either protein. The threshold for positive for GPC3 and AFP on the ROC curve was determined by the maximum Yoder's index value. Yoder's index summarizes the performance of the diagnostic test, often used in ROC analysis. Its maximum value is a function of both sensitivity and specificity and defines maximum potential of effectiveness of both biomarkers, referred to as the cutoff point. Its optimal differentiating ability when equal weights are given to sensitivity and specificity. Any patient below this threshold were classified as negative for AFP or GPC3. To observe the joint diagnostic efficacy of GPC3 and AFP based on their predictive probability, logistic regression analysis was adopted to establish a regression equation and construct an ROC curve. Logistic regression establishes a relationship between dependent and independent variables. This provided a superior efficacy discriminating hepatic carcinoma from normal controls. The corresponding sensitivity, specificity, positive and negative predictive values for GPC3 and AFP alone and in combination can be observed in Table 2. Associations between GPC3 expression and the various clinical pathological parameters were evaluated using chi-square test for categorical variables and the Mann-Whitney U test for continuous variables. Chi-square test is used for statistical calculations for testing relationships between categorical variables, whether the relationship of these variables is independent or dependent on one another within the population. The Mann-Whitney U-test is used to compare the differences between the ranks of two independent groups when the dependent variables is either ordinal or continuous, often referred to as the non-parametric t-test. These were appropriate statistical analysis for the data to draw these associations. When measuring GPC3 in hepatic carcinoma patients negative for AFP, the study found that it could be used as a supplementary biomarker for the diagnosis of hepatic carcinoma, where 43 out of 68 patients negative for AFP had elevated levels of GPC3, although they were unable to draw any significant statistical association. Whilst a positive correlation can be observed between GPC3 and AFP in hepatic carcinoma with a p-value of less than 0.0001, Spearman's rank was used to determine the relevance between these proteins in the different stages of hepatic carcinoma. Its analysis summarizes the strength and direction of association between two ordinal variables, in this case GPC3 and AFP. GPC3 was significantly higher than AFP in patients with TNM stage 1 and BCLC stages 0 and A, with a p-value of 0.019 and 0.006 respectively. An upward trend can also be observed with the increased stages of both TNM and BCLC tumor staging systems.
With the close analysis of the results, it was determined in the overall findings that the levels of serum GPC3 and AFP were higher in the groups of those suffering from primary liver cancers, namely hepatocellular carcinoma, intrahepatic cholangiocarcinoma, and combined hepatocellular cholangiocarcinoma, compared to those suffering from metastatic liver cancer, where the values obtained did not significantly differ from the normal control. Therefore, it was concluded that serum GPC3 and AFP were much more definite in PLC compared to MLC. It was further evident that the collected detection of serum GPC3 and AFP greatly enhanced the AUC and sensitivity for differentiating between patients with HCC and NC. With reference to a study conducted by a team of researchers at the Department of Anatomy at Jilin University, it was determined that serum GPC3 could not be used as an alternative in the diagnosis of HCC and primary liver cancer, but rather suggesting that the combination of both markers would yield a more accurate result. Therefore, given that the combined expression of GPC3 and AFP did not impact or affect each other in the AFP negative HCC group, it can be further stated that GPC3 is an effective complementary marker for the diagnosis of HCC. Although the level of GPC3 was found to be much lower in the ICC group as opposed to the HCC group, it was still concluded that the serum GPC3 may still be associated with ICC due to the values recorded being higher than the values seen in the NC group. However, future investigations may be necessary to truly understand the functions and molecular structure of the soluble GPC3 protein. It is also noteworthy that due to its lower levels in blood as opposed to tissue, only moderate amounts of serum GPC3 were exhibited in this study. In addition, the proportion of women was significantly higher to the GPC3 positive cohort as to the negative patients. In a study conducted by Matawe and co., it was revealed that samples from women contained higher GPC3 protein expression than the samples collected from men. This could mainly be attributed to the fact that the GPC3 gene is X-linked on the XQ26 region. Furthermore, immune responses exhibited in a recent study further concluded that GPC3 may be a good target of immunotherapy in the treatment of ICC, which can certainly lead to more innovative therapeutic measures in its treatment. To evaluate the association of GPC3 and AFP in HCC disease progression, the two popular staging systems, the modified BCLC and the 8th edition TNM classification of AJCC, were utilized. Regardless of the staging, the results established that the positive rates of GPC3 and AFP increased following upstaging. In addition, in patients with early stage NCC, the positive rates of GPC3 were markedly higher than that of AFP. This was not the same for the other stages. Hence, it was concluded that for early stage HCC, serum GPC3 was far more superior to AFP to serve as the sensitive marker. Now looking at the limitations of the study. The sample size was a significant limitation, particularly given that the CHCC-ICC group and the MLC group were both small. Hence, further studies with bigger samples would be needed in order to validate these findings. Yet another shortcoming of this study would be the non-representation of patients with benign liver tumors, and hence the expression of GPC3 in this group of patients was unknown and unavailable to be compared with those suffering from liver cancer and normal patients. Another vital limitation is the fact that the GPC3 expression in patient tissues was not calculated in this study. Hence, the true levels of GPC3 in the tumor tissues was unknown. Based on all the findings, however, it can be stated rather conclusively that the serum GPC3 expression before treatment is more specific for primary liver cancer than metastatic liver cancer. In addition, it complements the measurement of AFP and serves as a serological marker for HCC, especially in patients with early stages of HCC where AFP expression may be negative.